Yeah, but I also.
So when you're ready. It's recording. All right, welcome everybody to Cardiovascular Medicine Grand Rounds. It is my great pleasure to introduce today's speaker, Dr. Rohan. Khera is a cardiologist at Yale University, where he serves as the director of Cardiovascular Data Science Lab. He's also an associate editor for artificial intelligence and digital health at the Journal of the American Medical Association. Dr. Khera graduated from All India Institute of Medical Science as a National Young Investigator Scholarship Awardee. He did his internal medicine residency training at University of Iowa and his cardiology fellowship training at UT Southwestern Medical Center. Dr. Khera received the American College of Cardiology's Young Investigation Award and the Francois Aboud Young Investigation Award, in addition to being inducted into the Alpha Omega Alpha Medical Honor Society. For his work at Yale, Dr. Khera has received multiple awards, including the 2023 ASCI Young Physician Scientist Award, the 2023 Blavatnik Award, and the 2021 Jeremiah Stamler Award. Dr. Khera's group is developing and implementing strategies to improve outcomes for patients with or at risk of cardiovascular disease through data-driven innovations in delivering evidence-based patient-centered care. Dr. Khera's work develops novel applications in medical informatics, machine learning, and artificial intelligence to evaluate patient care and develop precision care solutions. His work spans broad digital data sources, including electronic healthcare records, EKGs, cardiovascular imaging, and wearable devices, with applications to modernize US and global healthcare. The work of his lab is supported from grants from the National Institute of Health and the Doris Duke Charitable Foundation. Today, he's going to be speaking about assistant and augmented AI and the cardiovascular clinician. So very welcome, Rohan.
Thank you. Let me turn it on. Can people hear me okay? Okay, perfect. Thanks so much for the introduction. I often feel like I have to sort of live up to the description of a broad portfolio of work, and I hope I'm able to do that today. And first off, it's always nice to be back in Michigan. I've been here a few times over the years in different stages of my career. I've always found this to be a place where there are a lot of friends, Brahmaji, Jesse, and Jeff, and everyone. And it's been fun to just be back as a faculty member talking to you everyone today. So I think my topic today is assistant and augmented and AI in the cardiovascular clinician. And my focus overall is just showing and showcasing that we are farther along than we think in where AI is in clinical care, but also have a lot of ground to cover. Here are my disclosures. I think the key one that I want to highlight is that I'm going to show some research tools today. And both the tools that I show are not meant to be used in clinical practice yet, but are still accessible to you. So I would just take that with that sort of like background information around them. Anybody who's been around AI in healthcare sort of has a sense that, it's been around, like what's so new about it? And I think the concern has always been that we're in this like boom, bust, boom cycle. It's going to be a big thing. And people thought before, like maybe a decade ago, AI will transform healthcare. Everything will be automated. Even clinicians will be out of business, or there'll be a new class of clinicians created. But then anytime we did actual clinical studies and clinical evaluation, it kind of failed to live up to the hype. And every single time the concern was, it doesn't really capture the complexity of healthcare, like how complex healthcare is. It's just not even encapsulated. And we were more oriented on this idea that we have cool technology and I need somewhere to apply it, rather than trying to fix a problem that was relevant to healthcare. And I think what we're seeing now is actually is solving that problem specifically. More and more, the stuff you see is problem-oriented design. And clinicians are becoming more and more an active partner in AI. And I know it's happening in Michigan, and it's happening all across the US and the world, where clinicians are actively engaging and say, I need this problem solved. And I think the work we are trying to do at the Cardiovascular Data Science Lab is focusing on this thesis. that when we have a problem, we have to use AI as a tool and solve the problem. So this solution-oriented development, has a central component. Define the, critical challenge that, is affecting healthcare today. Define the nodal points of intervention. Where would you intervene to solve the problem? What are the data sources that are available that you can leverage at those data sources and build AI tools for those sources? And finally, the solution should be tied to that nodal point of intervention for implementation. Because if you follow this path for development, I don't know what happened, but if you follow that path for development, you sort of have a pathway to implement back again because your development was designed with implementation in mind. So I have 3 topical areas that I want to cover today. One is, enhancing disease diagnosis using more accessible data streams. Second, I want to think about precision care. How do we provide care that is centered on a patient by learning more from the data we already gather and capture? And the third is, how do we optimize care as it's currently delivered? How do we deliver the most optimal care, the current care standards? How do we meet them effectively? So first, to go on disease detection. I think it's backing up a little bit. Okay, for disease detection, and the key thing that I want to highlight, and most in the room who are anyway tied to clinical cardiovascular practice, is that we have a huge challenge with underdiagnosis of cardiovascular disease, especially if you're thinking of structural heart disorders. People have them for years often before they are actively diagnosed. And often their diagnosis is on the onset of symptoms, not when they don't have symptoms, but have guideline-directed medical therapy that could alter the trajectory of their lives. And for most people who are asymptomatic, it's not like they're not even accessing health system. They are having different touch points in the health system. They're in contact, but they undergo a lot of testing that is not specialized in any way or in a way to diagnose the condition. So only a minority actually undergo the complex tests essential for diagnosis of condition, and only a minority are treated. So for structural heart disease, for example, 80% are not diagnosed before the onset of symptoms. And if you had to think about what that means in our society where healthcare access is not equal, is that people who don't have access to regular healthcare or don't have access to advanced healthcare end up being those who are diagnosed at much lower rates than even the average population. But I think there is an opportunity now that is progressively available. And the one opportunity is we are increasingly getting healthcare data from many sources before we come to the diagnostic test of choice. People across the socioeconomic landscape have access to a smartphone, and a third of the population actually has access to a smartwatch based on national surveys that we've conducted. And then if you look forward, people are getting health maintenance visits often, and it can be an ECG done for health maintenance visit above the age of 50, just one ECG that they got as their one health maintenance encounter. Or they go to the emergency room, they were coughing, and an emergency room provider put a point of care ultrasound to their heart just to check if the heart's okay. But in all of these conditions, even the experts in the room who are cardiologists who practice medicine are not able to use these tools effectively to diagnose many of the disorders that are undiagnosed right now, the structural heart disorders specifically. And even for the ultrasound, the clinicians are moving fast. They don't have the time to really use that as a tool and modality to diagnose conditions. So yeah, that's where we're left at, waiting for the echo, waiting for the cardiac MRI or CT to get us to the point where we diagnose somebody with a condition. So we wanted to solve this problem specifically by building AI tools for this early phase, where data is more abundant, more people get it, but our ability to diagnose conditions is limited by our skill or our ability to interpret those data effectively. And I'm not on the complex data, which has seen a lot of the initial AI development in radiology, interpreting MRIs, interpreting echoes. It's like getting it to the more common data streams more effectively. So I start off with the idea of using AI to detect conditions from electrocardiograms. And this is a domain that has grown exponentially in the last 5 years. And the central thesis of this, we would all recognize, especially who's ever seen an ECG on top, is that ECG is a 3-dimensional representation of the electrical activity of the heart. And it's not going to be normal conceptually in somebody who has a structurally abnormal heart. There's probably something abnormal about it. It's not that we just haven't picked up specific enough signatures for individual disorders. And increasingly, even though we have the ECG on top, we've increasingly getting access to 1 lead ECGs or up to 6 lead ECG on handheld or wearable devices. What's been interesting about 12 lead ECG based diagnostics for AI so far is that as a clinician, I would see the image on the right and say, okay, that's an ECG. But what people did effectively, especially led by a group at Mayo Clinic and other, now many places across the world, have taken the raw voltage data that plots out that ECG image and taken the raw voltage data to detect a series of disorders, building deep learning models to detect LV dysfunction, hypertrophic cardiomyopathy, cardiac amyloid, finding people who are at risk for a fib from their normal sinus rhythm ECGs, identifying other rhythm disorders. So, a big laundry list of conditions that we couldn't actually consistently diagnose from ECGs, but using that raw voltage data, being able to do that very effectively. I think the challenge with all of this work is that, who among us as clinicians have actually seen that data stream? I've never in my practice ever seen a raw voltage recording of my ECG. I'll have an image on my screen or it'll be printed out in front of me. And that's the thing I have access to. And that's true here, that's true across the world. So our question was, how could we use this image that's been around like this for 30 years? Yeah, it varies in layouts, where we put the leads, how many rhythm strips are there, it all varies. But the one that we will read has not been used effectively in any way, shape, or form. So in a series of studies that involved very specific method development, we went about doing just that. We built tools that in the first study identified a series of rhythm and conduction disorders directly from photos of ECGs. And the tools were built to be adaptable to any kind of ECG layout and format, and even artifacts that occur in images in the real world setting. And in the second study, we extended this work even further, identifying structural heart disorders from photos of ECG. And the central thesis of all this work is that we created a system to take raw voltage data and create images that resemble real-world images, but not only one kind, but a vast variation of ECG image types. And that too, we actually created new types that were not even in common use. So we were building a strategy for the models to be able to see a lot of variation in ECG. We introduced a lot of artifacts on the images, and we paired these ECG images that we had learned how to create with echocardiographic data, with gold standard clinical information, to now build tools that can be actually using the gold standard information and then actually use this image specifically as a way to think about the complex information that's already on the image. So as clinicians, we would see, oh, that's one lead, that particular waveform is the atrial activation, then depolarization of the ventricle. But then when we look aside, there are many leads, many different waveforms, and they all look different in subtle ways. And there's a lot of information that's captured over time. And our entire work has focused on using these complex data inputs that come from the images, build computer vision models instead of signal processing model, build models for the images, and discern patterns across this complex data streams to detect patterns consistent with structural heart disorders. We started with LV dysfunction. And an example of LV dysfunction specifically, in a study we published in Circulation last year, we showed that there are 4 lines on that plot on the left. That's AUROC curve, or receiver operating characteristic curve. And we found the performance of this tool that takes one image of an ECG to define if a person has low EF versus normal LV EF. That performance was above 90%. So you would be right 90% of the time if you picked an ECG, it belongs to a person with low EF or not. And we have multiple different formats of ECGs. They all have very similar performance. They're all 4 overlapping lines. And one thing I want to specifically point out, because we built it in our Yale New Haven health system that happens to be a diverse health system, we can confidently say that it works in older adults as well as younger adults. In our Black individuals, as people who are from our dominant Caucasian populations, and then Hispanic communities as well. Works in men and women. So I think the idea of broad demographic representativeness and broad clinical representativeness ensure that our tool is actually performing in the groups it needs to perform in. And I think what's the most interesting aspect for me is that you can actually scan this QR code and access this yourself right now. I won't use it in clinical practice. It's not FDA cleared as well, but I use this as a demonstration. It accompanies our study. But you can actually access this tool to upload an ECG and get a prediction on when somebody's ECG has high probability of being from someone with LV dysfunction or rot. And because we used ECG images and not raw signal data, it was so much easier to validate the tool. We got able to now send our application over or receive images, de-identified images from various sites, not only in the US. So the star on the top, in the left side of the screen is Cedars-Sinai, large academic medical center. But in the middle, Midwest, are small clinics and practices in Missouri, in Texas, who actually participated in validation with us, took a sample of people with low EF and not, and proved that in the images that they had, they were able to diagnose LV dysfunction using our tool. We sent the tool to Brazil in a prospective study where people had undergone ECG and echo as part of a prospective cohort study and were able to show consistent performance across the board. And I don't say that it works on images, just an example. The images we got and which it worked looked like the examples I see on the right. And so to show that the variation that these new deep learning models that use the entirety of the information and encode complex information successfully are able to accommodate the variations we see in real world practice. But there's also a discovery component to this. When we started this work, we focused on diagnostics. But when we found people who had false positive tests, like, there were, even with the discrimination of 91%, it's not perfect. There are people with normal EF, but the test said, oh, this is positive. We found that people who were test positive, which is the orange line on the screen, versus those who were test negative, all with low normal EF at baseline, people who were test positive were 4-fold more likely to develop low EF in the future. So a new digital biomarker for LV dysfunction, that actually, and we have adjusted for other aspects as well, still supersedes performance on other things, suggesting that we're learning new things about biology. And we've done some work ahead of this, and actually this is related to abnormal global longitudinal strain that is picked up by the ECG and is very cleanly separating between the true positives, the false positives and the true negatives. So there is a biological basis of the stuff that we are seeing on these practices. And while I focused on LV dysfunction, we built a series of tools focusing on ATTR cardiac amyloid from the ECG, hypertrophic cardiomyopathy, aortic stenosis, and including the tool with ATTR cardiac amyloid, which received an FDA breakthrough device designation earlier this year. So I think if I ask the question again, can we enhance the value of the ECG images that clinicians have access to? And I hope we would all agree the answer is yes, that with good models, AI models built for the images, we can enhance the value of that diagnostic modalities. And I think, while I focus somewhat on the aspects that are like cool and interesting around detecting structural heart disorders, even things like this, where you see an ECG, have a diagnosis there, it's a sign of privilege of being in a developed nation. And the developing world, if they're trying to triage STEMIs, trying to identify who has a fib and who has to see the expert, it's often a challenge because the clinician who gets an ECG often is not an expert at that, or there are not enough clinicians to interpret them, even though ECG device is so easy to use. So we've built now tools that take an ECG image as an input, and it's able to generate a full report, often exceeding the automated reports that we're getting, and generate a full diagnosis. We call this ECGPT, and we're now piloting this across the world as a strategy to see whether we can triage ECGs more effectively for a cardiologist read. So there are many applications that go beyond just the stuff that is hidden, but just the stuff you're so used to seeing can be made much easier as well, especially for applications across the world. But I focus on ECGs as if like everybody's had an ECG. And if you ask somebody with an ECG, again, I've not had a clinical ECG. So it really doesn't solve the problem of people who are not seeking care in our health systems. Like it's still a segment of the population. And so what I think, is helpful is to like go to the communities, to get where people are. And that's where I think wearable and portable devices really take us. I would argue that if you get a 30-second ECG on one of these devices, the image on the left is being done in a person of affluence and has resources, and probably can also get that clinical ECG much more easily. But I think the device on the right is very effective tool because it's not tied to an individual. And you can actually get a 30-second recording in a community care setting, where people are, and the same device can be passed on in 30 seconds. And the big push with using these for diagnostics for structural heart disorders is that unlike rhythm disorders that are paroxysmal or happen in the middle, but not all the time, structural heart disease is a persistent state of the person at that unit time. So if you got a good recording for 30 seconds, you've got all the information you need to get what you need to diagnose structural heart disorders if you have a good model. So it can actually be a tool that is used once for a window of time for designating a person. But the challenge is these data are not like clinical grade. Like they're not done with like probes stuck to your chest with like good contact, good, there's a lot of noise and artifact. Plus we don't have, a series of sort of like repositories sitting around with people getting their ECGs in practice and, these kind of ECGs and paired with clinical labels like, oh, this person had LV dysfunction and their Apple Watch ECG said that. That doesn't exist. And then when we're going to deploy in communities, we're no longer deploying in health settings. The prevalence is much lower. So your false positive rates are much higher. So you got to account for that before you go there. And then finally, even if we build tools, we found tools that work for low prevalence condition, everything. How are we going to integrate with our health systems? Like we don't actually currently have any way to pull this data systematically into our ecosystem. So we try to address these problems somewhat in our work. Specifically, I started with addressing how do we address the noisy acquisition problem with lack of large repositories. So in a study that we published in NPJ Digital Medicine last year, we said, let's use our clinical ECGs more effectively. We've got millions of them in our system. If we take lead one data from those clinical ECGs, but instead of just using data as they live, we actually noise them. We noise them with things we know happen when you acquire portable ECGs. So we add low frequency tremors, muscle twitching artifacts that occur from electrode motion. And there are like published data set on where the frequency bands lie. And we did random Gaussian noise, which is noise pulled from random areas. And we actually even accounted for things like electrical mains and like how that affects acquisition on a thing, because our clinical grade device is already doing all of that. They're subtracting all information. So we put that back in. And then we built tools that explicitly were adapted to noise. So the red line is the noise adapted model. The blue line is the standard model that didn't actually see noise ECG. What I'm trying to show you is the discrimination. So the value there is around 90%. When you start with a base model and you give them clean ECGs, it doesn't matter if you train them on noisy ECGs or standard ECG, the model does well, which is great. So the clean ECGs don't stump the model. But as you go from left to right, and the noise increases, and towards the very end, the noise is twice the signal. And we found that actually a noise adapted model was much more likely to consistently predict the LV dysfunction in this example. And if you just use the standard model, it starts failing, excessively. Identifying the strategy that we could use a potential way of like using clinical repositories with some thinking about how you will deploy it and use it in practice for diagnosing conditions like this. I address the condition of like prevalence specifically by not building tools for rare conditions, but building composite tools. When we are doing these things in the community, I don't need to know if they have HCM or amyloid. I need to know if they have any structural heart disorder that pulls them into the clinical domain to get them the clinical imaging. So we pull together LV dysfunction, left-sided, any sort of moderate to severe valve disease, and finally like LVH that is significant enough. So if we're not picking up everyone with hypertension, but something that is truly an infiltrative or restrictive cardiomyopathy. And we did that, and we were able to show that using the same approach as before with a very high discrimination. And the plot on the right is a precision recall curve, which is positive predictive value and sensitivity plotted to each other. And we're able to see for both of them, we have very high performance. So able to maintain AUPRCs at a level of 58 would mean that your false positive rates are going to be around, 1 in 2 or 1 in, 2 in 3 at most. So giving you the confidence that your echo labs are not going to get crowded by people who got scared by a device. And again, I think the last bit has been like, you just can't build models. You have to build solutions that do all the implementation. So we actually build an app for both iOS as well as Android. For iOS, because we wanted to pull from the Apple Watch. For Android, because we want to get to people where they are. And many people, especially, don't have access to an iOS device, but have maybe a Fitbit or can actually use the AliveCore device. And we're able to pull them effectively into a HIPAA compliant dashboard that can actually do predictions for HCM, for all our cardiomyopathy things directly using this app platform. And you can actually access it on the iOS store too. It's called Cards Plus. And I think entire goal is to us to be able to do the prospective studies more effectively without being tied to a vendor or a platform to tell us how to do this work. So I think we've spent a lot of time building this integration, which we hope can be used for broader research studies too. And I think while I, kind of focused on the ECG component quite a bit, there is something to be said about getting a look at the heart directly. When you're looking at the heart, you really have way more information when you're recording surface recordings, especially with something like cardiac ultrasound. The example I have there is a butterfly, by the which you can plug in your smartphone and can get, ultrasound of any part of the body. I don't have any funding tied to them. They just have very cool photos, and it looks really nice on a phone plugged in. And you can get really good images. Like you get sometimes these pretty decent images. Yeah, the only issue is they're not sonographer grade. They're not, people were trained to get those images. They're not the same grade. But we're doing them in our emergency medicine setting. We're doing it in our perioperative setting. Intensive care units are doing them. And then, progressively, especially outside the US, there are community-focused programs to diagnose rheumatic heart disease that are leveraging this pretty effectively. I think the big issue we have is that we train experts, not in the cardiovascular domain, to get some good views, some standard views, estimate some key elements, and move on. Like record, move on. But the issue is that they need to be suspecting deeper anomalies to be able to get the measurements done, but they won't do them themselves. They will have to refer. So there's like a activation energy tied to them identifying an anomaly and then referring for a certain thing. And in some settings that may be easier said than done, but if you're just doing it for somebody who's young and came in for a cough and you saw the heart's pumping okay, you're not going to refer them to echo just because you suspected the heart looks a little thicker. So what we decided to do instead is can we do something around this where we use whatever we acquire? For example, aortic stenosis is something I can, kind of see on the valve, but I don't know if it's severe or not, something that merits great intervention. And if I'm a ED doc, maybe I don't even see the valve. I'm just getting an EF and I'm out of there. How do you use that parasternal long axis view that you're getting without Doppler measurements and know somebody has, severe aortic stenosis? And the value is that you can start really opportunistically screening the ED. That every contact of a probe on the chest is an opportunity to screen. And we can do more focused community screening for people as well. So we built this tool last year using just parasternal long axis views and using without Doppler data, but identified gold standard people with severe AS versus without, and actually developed a model to identify presence of severe AS directly from just a simple parasternal long axis view video. And I think what we found in all of this is this is a population that was separate from the development population. We found that with very high discrimination, above 90%, but closer to 95%, we're able to identify which ultrasound of the heart comes from somebody with severe aortic stenosis. And the plot on the bottom is the probability of somebody having severe aortic stenosis. And what's really interesting to see that, was I didn't expect this because we tried to train on yes versus no. Okay, but we saw that if you had no AS versus if you had mild or moderate AS versus you had severe AS, those in mild to moderate were in the middle. So it was learning biological signatures of aortic stenosis, and probably it was highest among the severe AS population, but was not zero among those who were mild and moderate. And we developed and we deployed this in a temporally different time, in a new population that actually not had been in the era of the development population, still found very consistent performance in the same pattern at the bottom. And then we deployed it at a completely different site. Cedars-Sinai, we have partners there. We sent our model over. We never got their data. And they deployed themselves on their site. Again, very consistent performance in identifying severe aortic stenosis just from parasternal long axis views. And again, the same pattern is observed around increasing probability of AS or severe AS among populations. So what we really thought about, maybe this is actually something more fundamental. Yes, we have the diagnostic study, but what if this is actually a score, which we call the Digital Aortic Stenosis Severity Index, or DASI? Could this be something that can be used to prognosticate the development of AS or the progression of AS? So in a study that will present at ACC and will be simultaneously published in a journal somewhere that I'm not allowed to disclose right now, but in a couple of days I can apparently. If you go from, if you went with people, so the plot on the left is different, grades of AS or lack of so. So no AS, sclerosis, the valve looks a little thickened, but as no AS, mild AS or moderate AS, you have people with from blue to red, which is the progressively higher categories of that DASI score that I mentioned. There's a higher rate of developing AS, and the y-axis here is the aortic valve velocity across the valve. That's the one we use as a surrogate for the progression or the severity of the AS. The people without AS were more likely to progress to AS if they had a high DASI. Those with mild to moderate AS were more likely to progress faster than those with lower DASI. Now, these are categories that are consistent screening paradigms that you're supposed to scan everybody every 3 years when they have, mild AS. But what if a person has a much higher rate of progression? So this personalization is what we're trying to go for. The plot on the right just demonstrates that, like, if you build a risk-adjusted model that accounted for baseline velocity, baseline EF, age, sex, everything, there's a consistent relationship between DASI and the change in aortic valve velocity over time. Again, helping us think of a new paradigm of following up patients with AS, both de-risking frequent testing, but also up-risking and making sure people get followed up more frequently if they have severe disease. And then this too, we were able to sort of demonstrate both at Yale and at Cedars-Sinai, showing that at a low DASI, the progression rate was lower than a much higher rate at progression at a higher rate of higher DASI. And because not everybody in this like opportunistic sample of serial, not everybody got an echo at a good consistent period of time in this time limit study. We also checked whether we got people with like higher, severity index actually got more aortic valve replacements. That would be a surrogate for people we didn't pick up, but we didn't want to say like, oh, people got valve replaced. That's why we just missed that information. We actually found that actually people who had a higher severity index actually had more likely to have undergone AVR. And also it looks different in Cedars-Sinai, but we still saw that pattern is because they had actually a lot of people with mild disease. And only a subset of them actually had a high DASI. And that subset actually was much more likely to undergo a valve replacement. Again, confirming on a different axis on clinical outcomes that yes, it's picking up people who have the highest risk of progression. So I think, what we've done so far is taken images as they come, not worry about the complex measurements that we do. We've actually also adapted this tool to be like agnostic to the quality of the video and learn about like, oh, what's the quality of the video multiplied by the information it provides. And then use that information to detect a series of cardiomyopathies, including hypertrophic cardiomyopathy, ATTR amyloid, specific subconditions, not only valve. And then building digital biomarkers for both disease, forecasting who develops disease, but also prognostication on how the disease will progress. So I think, what I've sort of tried to do over the last, 30 minutes or so is to show that, we've been able to arm our clinical ECGs with a clinician-facing diagnostic app, our community-based screening using a wearable device or a portable ECG, and then also build tools that can work at point of care or, easy-to-use ultrasound devices. Trying to plug that gap that I sort of like, highlighted first about having this area of very high frequency data that's not used for clinical diagnosis for structural heart disorders. But I want to switch gears now. And I start with diagnostics for one reason. It's very easy to get the group like interested in that topic because people can understand the idea, oh yes, we need to diagnose more. What I want to get to is precision care. And it's a touchy topic because it's hard to know how to test that effectively. So what I present in the second half is going to focus on how do we define the optimal diagnostic and treatment cascade for an individual by using data from randomized clinical trials, but learning about individual response signatures. So we have built a series of applications of machine learning and AI deployed to randomized clinical trials. Specifically, we've built individualized treatment response signatures in trials. Then can we learn how would you translate the evidence, not to a person, but my practice, Trials are not considered representative of populations when we enroll them, but we have to deploy them in a population that we see. So how do you translate that information to your practice? And then finally, could we use the machine learning AI, pipeline to actually improve the evidence generation process itself? Could we make trials more efficient? And they're all interrelated aspects of applying machine learning and that statistical reasoning to clinical trials effectively. So the general way to interpret a randomized clinical trial is that you define the intervention you want to test. You take half the people, give them the intervention, half the people don't give them the intervention, assess outcome events in both arms, and then you find the average difference in events and say, okay, more people had bad outcomes in one arm versus the other. That's the treatment effect. That's the statistically appropriate way to interpret trials. I think that's the right way to do it. But I think conceptually, you can imagine there are people in a trial who have an event on the treatment side, but also people in the control arm that had the event on the event. So, people are having events in both sides. And yeah, we could call it noise that there's baseline risk, but is there any information there? Like who had the event in the trial, in the control arm versus the intervention arm? We don't use that information effectively enough. So we have done a series of applications over the last few years where we have taken a diagnostic test strategy, treatment strategy, treatment appropriate, how do you define treatment for blood pressure treatment? And I think before I go to the individual examples, I want to say the central thesis of this work is that randomized clinical trials are not case control studies. I never enroll an intervention arm person and find a person who looks like their equivalent, right? We just enroll half the people, half on the other side. And on average, those groups look similar, those on average. But what it really means is that if I'm a person in a trial, I look like some people more than others. I may be, 60 years old, and another person who's 60 years old. So they're very close to me in that on their axis of age. And I may have high blood pressure and the other person doesn't have high blood pressure. So they're far on that blood pressure axis. And then I have diabetes and the other person has diabetes too. So they're closer on that axis. So you can start thinking about each of these, table 1 characteristics of a trial as things that somebody's close to me on or farther from me on. And it could be like categorical things. It could be the actual blood pressure value or everything in the middle. So if you can conceptualize a trial, it's a multidimensional universe where each person is close to some people on some dimensions and farther from the others. So we use this conceptual framework of building this phenotypic space of trials and build this idea that some people are closer to you and some are farther. But the interesting aspect that randomized clinical trials get, which observational data doesn't, is that everybody has the equal probability of getting the intervention or control. So regardless of where you live in this multidimensional space, you might get an intervention, might get a control because that's random. So this particular example in the middle is a projection of that multidimensional space. In this example, there are 75 covariates or features we took from people before they were randomized to treatment or control, plotted this 2-dimensional projection of this multidimensional space. And on average, the greens and the oranges suggest that, yeah, it's kind of balanced throughout. Like, yeah, there's no area that's like, that's where people got intervention, that's where people got control. It's everywhere else. And then we took each person in the trial, defined like their unique neighborhood. And I said, okay, if I'm the person in the trial, give me the outcome effects that happen in treatment and controls around me, weighted by the distance they have from me. Because if they're farther from me, their information is less relevant. But treatment and control is happening at an equal frequency as you go away from me. And we use that weighted information to build these models to identify, okay, for this person, their hazard ratio was this, which is the effect estimate of how much effective the treatment was. We did that for the for a second person in the trial, and again did the same thing. Build a tool, build a Cox proportional hazard model for that person, weighted by everybody else in the trial. And we did that for each person in this trial. For this example, it was a 10,000 person trial sprint, which tested high intensity blood pressure lowering. We're able to now essentially repeat this experiment 10,000 times. And then what we do is we try to see what are the individual, because there's going to be noise, right? There's going to be random chance that some neighborhoods have a lot of events and some don't. We wanted to see what patient characteristics were associated with a good response to treatment, more frequently than not. And we use that second order learning from these 10,000 data experiments to build a series of tools. So the first tool is able to identify those who benefit on a cardiovascular side from getting stress test or CTA for their initial presentation of angina. We developed it in PROMISE trial, which is a null trial, and actually use that tool and validate in a Scott Hart trial on people who had got stress test and CT as first test. And we're able to show that that signature is able to pick up who benefit from one testing or the other. We're able to develop not only in like null trials, but we took SGLT2 inhibitor trial called Canvas and said, okay, the trial suggests it's super positive. We're able to identify people who actually respond to canagliflozin for their cardiovascular outcomes and tested in a second trial called Canvas R and found a similar signature that the trial effect is driven by a subpopulation that actually derives a majority of the benefit. And then finally, SPRINT was a positive trial and ACCORD was a null trial. And there are population differences. We built a tool for treatment responders in SPRINT, deployed that in ACCORD, and found that ACCORD for those populations based on the SPRINT score was positive, suggesting again that there is a population feature that defines characteristics, and you can actually learn those signatures from these trials. But I think, that's the harder concept to test prospectively, because am I going to run another SPRINT trial now with an additional tool built in. So it's actually, we are still discussing with a lot of funders, it's what's the right mechanism to test these care individualization tools, because they need to be prospectively validated for them to be used in practice. But what I can do maybe a little better is like, I just want to know what I should do about my practice. So if I'm in Michigan, Sprint was done actually across, the world, so it's an easier trial to go after. But like say a trial was done in the Northeast, how does it apply to patients in my practice? And because there are patients like mine in the trial, but they're not the majority. I don't want the effect to be driven by them. So we started to use a new strategy of using digital twins, but adapted, conditioned digital twins, when one population represents the other. So what's the framework here? The framework is that you have a randomized clinical trial. It's a sample, a non-random sample from the universe of people who fit the inclusion criteria of the trial. It's not like you had 18 to 80 as the inclusion criteria for age groups and you have a good spread of age. It's often localized in a specific area. And what the challenge is that if you can't really test the idea that, oh, if a new population had been enrolled in a trial, you would have had a different result, because that truth is unknowable. Otherwise, we would have done it, right? We would have run the second trial in a broader population. That truth is unknowable. So we said instead, okay, we have two trials that tested the same intervention at different outcomes. Okay, but what was it in these trials? Like, could we run Sprint like with the cohort participants? Could we run a cohort with Sprint participants to see whether participant characteristics were the reason the two trials were different? And so this is what we've tried to do so far. So we take in one RCT, which is an index RCT in this example, maybe Sprint, an external cohort, could be RCT, could be EHR. We define a set of shared covariates, like what are the features that are shared between the trial and the second trial or the EHR. We actually don't just go crazy and say, okay, table one, take tabular data from one trial, take tabular data from the second trial and just merge it in and build a hybrid something. No, we actually encode the associations. This is the exposure. This is the intervention of choice. This is the outcome. These are the directional things. So for statisticians who might be listening, we use DAGs to represent these statistical associations. So we built a statistically informed digital twin strategy. And so they are clinician and expert defined technically. And then to build a generative adversarial network, which is conditioned on a different population. And what we did was we conditioned them with patient characteristics from a second population instead of the first one, to now start building a twin that, instead of seeing the age distribution from Sprint, it was seeing the age distribution from a cohort. And we didn't do it for one feature. We took 10. And we pulled all of them together and tried to see whether the most discrepant features between Sprint and a cohort, leaving alone the diabetes and other features that were just remarkably different, the features that were measured and were just off by a bit, whether we could replicate the two trials. So the plot here, we could run the twin any number of times. That's the cool part about it. Once you build a model, it can keep generating twins as many times as you want. So the line is the hazard ratio of 1. A cohort is the green dot, and it's a null trial with a leaning towards being positive, and that crosses unity on both sides, right? This is the same plot represented twice. And the Sprint trial is positive, so that's the diamond, and it's actually a positive trial. So when we conditioned an accord, we took a cohort trial, built a digital twin of the accord using Sprint participant characteristics. We were able to turn the accord trial that was null into a series of positive trials that resemble the Sprint trial, identifying that the characteristics of Sprint would drive the effect estimates seen in accord. We also flipped the script and took Sprint and took accord participants and developed a thing. In a majority of these runs, the accord was not significant, suggesting the idea that the trial differences are emerging because of differences in population characteristics and the treatment effects observed in that population, rather than something natively different about how we measure blood pressure or other things, which might be playing a role, but maybe not the dominant role in how these trials became different. And while only show an example of an RCT, our goal is to build standards so we can actually use it in EHR and have safety bounds to know, okay, this is trustable information for my practice, and there's a new drug tested in a population. Am I going to put it on my formulary or not for my population? Those are the kinds of decisions we want to arm to not be driven by, gestalt, but by actual data. And this is the hope that we can get there. And although I've talked about the clinical applications, the applications to RCTs, I think are very profound, because currently we do a study in RCT. We started, we ended. If we are very creative, we do some interim analyses. Either we'll like take the traditional route of using this interim analysis to say, okay, this drug is safe, can continue. It's futile, don't do it. It's unsafe, stop the trial. Okay. Or we'll be creative and do it. Let's go adaptive. Okay. We'll enroll more people in the control arm or the intervention arm to make sure we drive the effect where it's already heading. But what we don't do is we don't actually learn anything about the effects that are already happening in the trial. The trial's accruing events during this window, and we don't use that trial effect. Again, this is still a thing that we're discussing with the FDA, how we would typically implement it. But our goal is to take interim analysis, run our heterogeneity of treatment effect assessments, like these individualized treatment effect estimates, build a tool that defines who is a high responder, but don't let it encode information on age, sex, race, or ethnicity, but just on the clinical parameters that we're already selecting our patients on. Like we choose who goes into a trial, and especially doing multiple assessments, you want to choose the people who are right for a trial. And then essentially build an enrichment model. Don't only enroll from those populations that are high responders, but enroll them more frequently. That's all we say. Enroll them more frequently. So stochastically enrich the trial. And we found that an example of this, we've done it a few times. These are all post hoc because we can't do it in live trial yet. We took the IRIS trial. So this is a trial of a patient who had a stroke or a TIA, had impaired glucose tolerance and were given 5-glitazone or placebo. Trial ran for a long time, had a series of interim analyses. And the final population, which is the red here, had, about 3,900 people. We found that if you ran the interim analysis when you start building our tool, and the teal thing is a negative control. We said, okay, enrich based on some random characteristics. The blue is where it's enriched by a tool that we built. And we found that as time goes on, in each interim analysis, we improve the tool further. We're able to reduce the size of the trial by 15%. That's about 600 people. And for a CVOT or cardiovascular outcomes trial, that's $40,000 per patient enrolled. So it's a large amount of savings. So you don't even have to have an aggressive reduction like 15%. Even modest reductions might get you really far. But it doesn't come at the cost of changes in the effect estimate or the p-value, even if you account for the multiple testing that you're doing as part of the original testing. So again, this is a construct we are hoping takes up on, but we're still looking at what does it mean for the drug? Will it have to be used with a tool in conjunction for selecting the patient? Is that a horrible thing if you had to do a calculator for an expensive therapy? Probably not, but we're still trying to work with the FDA to figure that out. So the last bit, I think, I've spoken a bunch about things that might be on the horizon, but what about stuff we already do? We already think about clinical care quality, and we know we don't do a perfect job at that, of stuff we know already works. And this is stuff that this is my background. This is where I started as somebody who does quality measurement and improvement as their work. Now, our goal was, can we use computational approaches to arm our clinicians and our care to improve quality, and our policies to be armed by that too? So, and I think what we've tried to go towards is this idea of fully electronic clinical quality measurement. So that we have these next generation registries. So no longer the NCDRs that have really foundationally informed that measuring care quality has a potential impact on the direction of care we deliver, but can only deliver it to a 20% of the US hospitals who have the resources to participate. So instead, the idea is to build EHR native models that are interoperable across EHRs. So it's not the Epic sites only, but every site that has EHRs, which is mandated as part of law, then actually make it so that it's not about claims. It's about what clinicians think a disease is. I know when my patient has a disease X and Y, I document it too, but that's never factored in the claim that's submitted. And then finally, we document all that stuff in NLP, make sure that clinicians are not clicking extra boxes just to give us a better quality measure. This should be not intrusive. Only then can it be successful. And if anybody is talking about interoperability, I think the cleanest example is that if you go from one EHR platform to the other, I don't think Michigan's migrated platforms, but if somebody's ever migrated from some other platform to Epic or has gone from one Epic build to the next, you know how disorienting it is to go from one to the other. Even though you're looking at the same clinical characteristics, you can't just find it. And that interface variation is X-fold higher. I don't even know the X there. In the databases that construct the EHR. That's what I'm going to leverage to build a tool. So it's not very useful to think about these data sets, because if I build a tool in the data structure in one hospital, I can't actually get the data, the entirety of the EHR data from a second hospital to just play with. So I'm going to send my tool over. And either somebody adapts the tool to their local ecosystem, but more likely than not, it just doesn't work in the other system as effectively. So what we've tried to do instead with the correlation of the willing, I would say, we mapped all EHR data to a constant and consistent data format. It's called common data models. And OMOP is the word I use here because you'll hear more of it because NIH has picked it up as one of their standards. And people are mapping EHR data to OMOP across sites. And this is standard terminology. We will use this for this field, that for that field. These are the codes that will be used. It's actually intensive clinical work that pays dividend in the end, because once you build an algorithm or toolkit for the OMOP data model, you can now go across firewalls, deploy in systems. And actually, because the mapper was built inside, it actually can reverse propagate into the system's operations if it had to arm quality improvement programs as well. And I think the key thing that we've tried to do is we built this partnership called Legend Diabetes, where we actually did this. Multiple claims partners, multiple EHR partners, mapped the data to OMOP, and we're testing like, hey, first off, who's using SGLT2 inhibitors and GLP-1 receptor analogs as a second-line diabetes drug? Again, it's not recommended in guidelines yet that we have to do it, but it's still like a practice that we've like tried to follow. So we said, okay, for 4 hospitals, Columbia, Hopkins, Stanford, and the entirety of the VA, that's 130 VAs, said, okay, compared with the European standard, if we benchmark, we have the ability to benchmark now. A European standard of the data sets we have, we were much lower in 2018 on SGLT2 inhibitor use across groups. But most of these hospitals were actually performing at average level of the other US hospitals. So we have the ability to benchmark because we have data from so many sites. But as 2021 rolled around, we've started seeing a big uptick in SGLT2 inhibitor use and actually meeting the European market, these hospitals, and the hospitals that are participating in are actually above the national average. So suggesting that there has been an uptick. And again, on GLP-1 receptor analog side, Europe use was much lower. And except the VA, the other sites were doing pretty well. And maybe it was part of the fact that obesity was a big player. And we later found out the VA had policies against using GLP-1 receptor analogs as a second-line agent in diabetes, that was not the recommended formally strategy. So that was the case. And we found that the hospitals were like consistently now also using way above the European usage. And actually, these hospitals are actually much higher than national average. And while I only show 4 examples, the idea here is that we can actually start learning across hospitals, and that's actually very effective. And I think the other thing that we do is because you're doing it at scale, we can start aggregating this learning. Like we want to compare SGLT2 inhibitor to GLP-1 receptor analogs. We found that actually AMI risk is reduced with GLP-1. The right side favors the horizontal axis, the left side favors the vertical axis. And we found there was actually a favorable signal for MI with GLP-1 receptor analogs. What we were surprised to find was heart failure signal wasn't different between GLP-1 receptor analog users. And we thought initially this must be a data quirk, we're just not accounting enough. But increasingly, we're seeing trials of GLP-1 receptor analogs coming out. You know, the STEP-HFpEF trial is one example, many more in the mix. So I hope we're forecasting that heart failure signal is not tied alone to SGLT2, but weight reduction and other things in GLP actually help improve heart failure generally. And we also were able to finally start comparing with DPP-4s, which are neutral, but show that actually the MACE outcomes are improved with both SGLT2, GLP-1s, and that sulfonylureas are inferior to all of the 3. And again, stuff that we won't test in head-to-head trials. So I went off script only for a little bit, but I want to say for quality measurement, I really want us to think about a future where we go from the traditional of not measuring processes, only measuring outcomes because they're the ones we can only trust. And then, there's so many ways to game those inputs with how you code the encounters. And then we don't even think about quality improvement. Like the quality measurement associated from improvement, separate processes, measurement happens in 2021. You see the report in 2023. Like, I don't know what to do with it. And so instead it's like, learn about the processes that we can change. Think about how we will actually work at the point of care for measurement so we can actually impact care there. And then safeguard against gaming. So take it away from the hands of coders and clinicians and everyone. Let them do what they're doing and measure outside of that construct. So an example of that is we know HFrEF, heart failure reduced EF, has low GDMT use. But we don't know how to know who has HFrEF in our health systems. People get echo at one site, come to the other side, seek all their care. How do I know they have HFrEF? EF might have recovered by the time they saw us. Doesn't mean they get poor care. And that's why I think there is no quality measure nationally, because we can't do this effectively. So we took clinical notes in people with heart failure hospitalizations. We built this new lightweight transformer model, which is able to learn not the presence of EF, HFrEF, but learn how it's mentioned. No HFrEF is different from HFrEF. or EF is preserved is different from the mention of EF or no. So it learns the signatures and picks up which features are actually defining it. And then we used LVEF, we like chart checked and did a manual extraction, learned which who has low EF or not, historically even, and found that ICD codes were like missing 60% of people who had HFrEF, just the ones that we would use in practice. But our approach of using NLP is able to pick a majority, above 95% of people who have known HFrEF without actually classifying those who don't have HFrEF. So making sure that we can actually start building a future. And again, this is only part of the work we've done. We've built tools that pick up adverse effects, N by H functional classes, just identifying a full composite metric that we would consider appropriate care in practice. And I think the last couple of things I would just say that our goal here is that we want to build interoperable tools that can combine on common data models, build specific language models for tasks that are easy to deploy in low resource settings, and then deploy without risking patient privacy. So now you have got fully automated measurement of care processes, and you interface that with quality improvement and keep a cycle going where you can measure quality, measure the quality after the improvement initiatives. And hospitals that don't invest are the ones that are probably appropriate to penalize or at least evaluate for what's going on with them. Because it's hard to do that right now without having such ingrained assessment of input without any investment from them. I don't go into too much detail here because this is stuff we've discussed theoretically in many platforms, that all these tools are still early stage. We have to think about validation, about regulatory standards, how we ensure that we can interpret them so clinicians can start building trust around them. When do we tell people that this while we get giving you a model output, it's too uncertain to actually act on, don't trust us. I think that's where we have to really think about how clinicians think. They want confidence and they want to know when they don't have the confidence so they can make decisions on other cues. And then how do we overcome bias that occurs and creeps into the algorithms as part of developing them? And I think that's stuff that we're still trying to solve. I do say that I put in a plugin that we are trying to build this loose correlation of the billing where we share models and you share models and we can validate without actually sharing data. We call it Precardia, and many people have joined and done a lot of cool work across the world. And Brahmaji, thanks for joining in some of the work, and hopefully we'll finish it soon. There's been a lot of foundational work we've already invested in it, so it's great to do that. I think with that, I'll just start with this, that we have digital availability of a large number of data sources. And I hope I've convinced you that AI can both assist clinicians in doing what they already do, but also augment human capacity in ways we didn't know we could do. And then technology that's built for data as they are, rather than modifying the entire ecosystem just because my tool should work, is actually probably not the right way to go about things. And then, innovation with AI spans all aspects of, we'll build biomarkers, we'll change practice, we'll do end-to-end discovery and innovation in care. And that's part of what AI can do. And then finally, we have to keep, be cautious about what we're learning, where we're missing stuff, and how do we measure the impact of our intervention. So all this work would not be possible without the exceptional team that I get to work with, who are always leading all the efforts that I get to claim as ours. And with that, I'm going to stop and answer any questions.
Thank you, Rohan. That was an excellent presentation on how data science and AI can be integrated into the medical system. I'm going to start with a simple question. You probably heard this before, but AI has been in the news quite a bit lately. It's been a little bit polarizing, and there's a lot of people that are concerned about AI affecting their job or affecting how they deliver care. How would you counsel somebody who's a little bit on the defensive end of the spectrum?
I think it's always great to have a little bit of skepticism is good, because I don't think actually we have everything solved, and actually having folks who are skeptical about where we might go, I think that's actually a good thing. Second, I would say you would counsel by the fact that every time new technology comes out, there has been concern whether it would change how we deliver care. When if we could have thought about any new blood test, so a CK creatine kinase manufacturer might say, okay, I know troponin comes around now, my CK is not relevant anymore. Or so there's this evolution of how we deliver care. We don't need a chest pain monitoring unit that runs for 48 hours for us to know if somebody doesn't have MI by using a high sensitivity troponin at presentation, and that's okay because our care processes will involve. our workforce will skill differently. And I think all of that is like part of development, but also won't happen overnight.
Any question, Brahmaji? Thank you.
Rohan, that was. I had a question about, you mentioned many times like regulators, like the FDA that you're working with. Also, like, just curious about the financial model for many of these. We've seen technologies come and they've helped, but if there's not a business model within healthcare, especially in the American healthcare system, they have just failed to be adopted. How have you thought about that?
So I think, the things we're trying to do is like, is you can think about it in two ways. One is it something that really makes us as health systems really change how we structure everything? If that's the case, then the investment from health system is just too massive sometimes to really justify changing the workflow to incorporate one piece of technology. There's an increasing interest in building a middleware strategy where your tool has to comply with our data standards. And then we can actually like incorporate a series of tools that way, because it's impossible to say, okay, I have an EF tool, company Y has an EF tool, and company Z has an EF tool, which one I'm taking. There's another tool that comes in, like how are you going to arm everything? So I think the business model is to make it so low cost to deploy that the actual intervention makes it much easier to like get integrated into systems. And second, I would say it's still because it requires FDA clearance. It's not going to be the academics who deploy in care. So it has to be this partnership. So, and I include in my disclosures, Yale's actually backed us to create startups in our group to actually go to the FDA and actually learn that process ourselves, but not go to the very end of me commercializing to the, and selling. But I can actually learn the entirety of the process and actually design so that it's more integrated into the business case. And I think for AI ECG specifically, there are now CPT codes, and CMS intends to reimburse AI ECG at a certain dollar amount, like the CTFFR is reimbursed at a certain code for heart flow that runs the CTFFR. So there's a technology add-on payment that's being added to all of these things. So that will cover a lot of the point of care AI technologies. But there'll also be other things that I think don't and will integrate into the value-based care or the fee-for-service model, that it reduces heart failure hospitalizations, or it allows us to capture people and do a lot of testing. And I think both these cases can be made on depending on who you're talking to, which I mean, I hate to say, but we have many different like perspectives in our health system. There's no unifying ideology even. So come to a private practice, you might have a tendency to like, this helps me like get a lot of people in the mix. And in an integrated system where you control the insurance dollars, you want to pick up people and make sure they don't develop the advanced disease that is preventable. So I don't have a great answer, but I would say there are multiple models that are emerging. Some will be paid for directly, and some will be like covered by our health system's general interest in diagnosing these conditions early.
Go ahead. Sorry, Jeff, behind you. Press it away.
There we go. Wonderful lecture. My understanding of most AI models is they become more and more effective based on how much data they hoover up into the model, certainly generative AI models. Given the HIPAA laws and privacy concerns, as you try and make these models more and more effective, how is that going to be regulated? How is that going to work given the regulatory structure around privacy?
I think there's a lot of very good questions that are embedded in that one question is like, how do you build models and continue to use a lot of data to develop them versus a little bit of data? There's been an increasing push about building general purpose models that are like not tied to a certain task. People use the term foundation model pretty frequently for that. And then using them with small data environments that you will have access to in one particular system to develop a specific application tied to that system. So that's the way that people are now using these large, the ChatGPT models are actually foundation language models, and you can adapt them to do diagnostic work on top. So you don't need to share data, you share models. I think that's one approach that people have done is to actually take models, move them site to site, and keep improving them, because the input can be used to fine tune the model, which is improve its like performance at different sites. And I think the other aspect I would say is actually regulators are not ready for adaptive models. they're not ready for, they want a static model that has performance characteristic X. That's the AUROC, this is the sensitivity, this is specificity. You get this input, you get this output. They're not ready for a model that looks like something in 2023, something else in 2024, and something else in 2025. There is a new rule around predetermined change control plan that FDA just instituted, which is you can discuss with the FDA when you're going to update it. So I think even that's not clear how frequently could you update. And so I think there's some more sensitivities around how it can really adapt and improve, more so than build a robust model from the get-go. And it's not perfect as it can be, but it's closer to it.
Jeff, we'll take one last question.
Sure. So Rohan, wonderful talk. And actually, Dr. Golis and I were just commenting, amazing slides. They were very clear, easy to follow. So really, really well done.
Thank you.
The question I have for you goes back to the beginning, and it's maybe sort of tangential to what Ramaji was asking earlier. You know, the development of these diagnostic tools is incredible, but if we can't get them into use, then sort of what's the purpose? And I'm wondering if you can share some thoughts about what's the format that you need to put this in so that it can actually be implemented broadly, right? A lot of these right now are in an app. Do we want to require a clinician to pull up their phone and take a picture of everything and that barrier? Like, do we have to get this into Epic? Do we have to get this into the ECG machine and deal with all those barriers? And how are you thinking about that?
So we try to solve them. My goal is democratization, and I'm trying to see that if I need to talk to an ECG vendor and 10 of them, then I failed to like really democratize stuff because now I'm tied to their whims. If I'm tied to like an EHR vendor to allow me to integrate, then I'm like sort of also. So my goal is like democratize access, but it like doesn't restrict us from going to them as a second order to like, hey, this is a clear tool by the FDA. Anybody can access on the phone, but we think we can make it easier to use by actually using a screen. When you pull up the ECG, it just runs on the image itself or on the back end of the Muse system itself. We've tried that at Yale. It works very well. We've actually done like on screen, like as soon as ECG pulls up, you can click and say, give me the prediction. It does the segmentation of the area and runs it on the system, not on the cloud. It's light enough that it can run on the system. And we've done that again as pilot studies. But I think, are we ready for like EHR vendor and negotiations? I don't think I am ready for that. But I hope like eventually when you have a tool and everybody wants to use it, that there would be an easier path forward if anybody can use it, but it can be easier on the EHR side.
Todd, we'll take one last question. Go ahead.
I really enjoyed that presentation. So hospitals are compared by national organizations for mortality, readmission rates, length of stay, and in some ways their costs are determined by documentation and so those things are reviewed. Like, so the details of the documentation are really important, that they be accurate and complete, so that you get full recognition of the severity or the complexity of the patient that you're taking care of. How much AI is being used out there to generate the documentation and notes in hospitals? And what are the ethics of that? If a computer writes an aspect of care into the note, is there anything that demands that it actually be read by the clinician and considered? If it's in the documentation, it seems like it's a very slippery slope.
No, I think we've already sort of like gone on that slope since we started using Epic templates, and copy forwards. We've been like using a lot of the information that was not written by us often, and actually that's problematic. But I think the general result is the same. We are all liable as clinicians to anything we sign. And that doesn't change at all with if you generate the text automatically or generate with a dot phrase or generate with something else, it just is the same. And there's a lot happening in ambient note-taking where you record the conversation. You don't translate the conversation into text or don't just move the transcribe the thing. You actually interpret, learn the meaning that was presented and turn that into a note. And there are actually like 10 companies doing that right now. And every hospital is piloting that. And I think the end result of that would be you'll have a conversation with the patient. And I don't know the quality of the note writing, but if the note writing is sufficient quality, it'll be added to the note directly. And that's the draft you start with. That's the draft you start with, and that's what you build on. And I think that quality then can still be high if you did document everything. But also it's actually cool because you can stop saying we did a lot of things, but we don't do. And I think that's something that is always, again, that's a question that are we ready for that? Because there are clinical encounters that are fast and comfortable for the patient and the clinician, but don't meet the documentation requirement for a level 3 encounter. And I think that's something to be said about that. And I don't know how CMS will react to that lack of information.
Thank you so much. Of course. It was a great presentation.